Hi everyone, my name is Jessie. I'm a third-year PhD student in biostatistics from the University of Pennsylvania. So today I'm going to introduce the DGEM COVID project initiated by Jenna from Jason and Dr. Yongchen, my advisor from UPenn as well. And this project, we have the aim to conduct a distributed network analysis of hospital profiling on COVID-19 mortality rate. And when we talk about hospital profiling, we have the goal to compare the quality of care between different hospitals. But when we do the comparison, the challenge is the case mix situation, which means different population across different hospitals exist. And for some of the hospital, they will have severe patients compared with the others. So with this challenge, the question we ask is, how can we make fair comparison across different hospitals when we have the case mix situation? And the solution we came up by taking mortality as an example is that we can evaluate the risk standardized mortality rate by counterfactually treating all patients at a given hospital. And the idea of counterfactual can be explained as this. So usually one hospital only treat their own population or only treat their own patients. And by adopting the counterfactual idea, all of the patients that we are interested in across different hospitals, we can pretend they can be pulled together and treated under different hospitals. By adopting this counterfactual idea, we can see that all of the patients will be treated across different hospitals. And when we look at their outcome, for example, their mortality rates, the comparison between their outcome across different hospitals will be fair enough. However, in reality, if we want to adopt this counterfactual idea in like multi-site format, the challenge is that if a hospital wants to participate in the ranking, but they cannot share their patient level data, how can we achieve this hospital ranking or hospital profiling study? And the solution we came up is the DGEM algorithm, which stands for Decentralized Algorithm for Generalized Mixed Effect Model. And this algorithm is a federated learning algorithm. And in this algorithm, there's no need to transfer patient level data. And in this algorithm, we only need some aggregated data, and we only need the transferring of hospital-specific effects. And in conventional idea, if we want to pretend the patients can be transferred across the different sites, we transfer patient themselves. But as I mentioned, in reality, due to the patient privacy issue, we cannot transfer the patient level information. So in our DGEM algorithm, we propose to transfer the hospital effects, which is the gamma we present here. And these two ideas, they're equivalent to each other. So this is the rationale that we came up with DGEM algorithm by adopting the counterfactual idea and also we preserve the patient level information. Okay, so in our DGEM COVID project, the method we are going to use is the DGEM method, which is privacy preserving, communication efficient, heterogeneity aware, and also hospital level calibration is considered. And this is the DGEM workflow. In our DGEM algorithm, we have three main steps. For the first step, each hospital will share their will estimate and share their initial estimates of the association between patient level variables and the outcome. And then for the second step, each hospital will use a meta-estimates from the first step to estimate their own hospital level effects. And this hospital level effects will be combined together to do a hospital level calibration. In this calibration, we use the meta-regression as the technique. And in this meta-regression, we consider the hospital level characteristic to do the calibration. For example, we calibrate the number of ICU each hospital has, or local COVID-19 burden, or for example, the number of visits back in 2019 or 2020. So after this hospital level calibration, we have a calibrated hospital effects, which we use gamma 2 star to represent it. And each hospital will use their patient level data and use the calibrated hospital effects to calculate the counterfactual rates. For example, in this example, we have 4 different hospitals. So each hospital, their output in step 3 will be a vector with dimension 4 times 1. And at the end, all of the hospital will contribute their counterfactual rates together, and we form the output of DGEMM algorithm, which is a 4x4 matrix. And this 4x4 matrix will be used to calculate the standardized mortality rate for comparison. And in our DGEMM COVID, we are going to, for the cohort, we're going to consider 2 different time periods. The first one is the alpha wave, which is around November 2020 to February 2021. And the second wave is the delta wave, which is around July to August last year. The reason we're going to consider 2 different time periods is because in hospital profiling, we want to compare if all of the participants, or like all of the hospitals, they performs very similar across different time periods in COVID-19 when they're treating the COVID-19 patients. So this will be very interesting to see if they perform consistently or they improve their performance, and we can dive further into it to figure out if they increase their number of ICU or they improve the nursing, some other like scenario that will help us to explain different rankings or help us to see if they perform similar. And more details about the cohort is that the outcome we're interested in is a binary outcome, which is the COVID-19 mortality status. And the measure for hospital profiling is the standardized COVID-19 mortality rate. And the variables we are going to analyze include the age, child's comorbidity, gender, history of other disease, and the hospital level variable we are going to consider is the number of visits back in 2019. And the target journal is Nature Methods, and we are planning to submit it sometime in July this year. And to implement this collaborative study, the DGEMM COVID-19 study, we're going to use this platform, which we call PDA-OTA, stands for Privacy Preserving Distributed Algorithm Over the Air. Since in this project, we are going to have some aggregated data. For example, you can see we have the initial estimates data, we have the calibrated hospital effects, the gamma. The way we transfer these aggregated data will be implemented and use this PDA-OTA platform. On this PDA-OTA platform, we are going to create 2 different projects for 2 different waves. And within each project, we're going to transfer the aggregated data in JSON file. For example, we have 3 steps. So we have JSON file initialization step, derive step, and final estimate step. And each participating sites can upload their aggregated data through this PDA-OTA. And use this platform, you can track our project status. Since we have 3 rounds, you'll see like which round we are working on. And this is the GitHub page of our DGEMM COVID study. Please feel free to visit. Right now, we have more than 20 sites are contributing their data, and we hope to get more participants in our study. So if you're interested, please feel free to let me know or let Jenna or Dr. Chen know about your interest. Yeah, that's the end of my presentation. Thank you very much for listening.